Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Elective Cancer Surgery in COVID-19-Free Surgical Pathways During the SARS-CoV-2 Pandemic, an international multicenter comparative cohort study by Bhangu et al. My name is Ken Tanabe, and I serve as Chief of Surgical Oncology at Massachusetts General Hospital, Professor of Surgery at Harvard Medical School, and Deputy Clinical Director of the Massachusetts General Hospital Cancer Center in Boston, Massachusetts. My oncologic specialty is surgical oncology. The devastation and destruction brought about by the SARS-CoV-2 pandemic is difficult to fully comprehend. At time of this podcast, there are more than 28 million infections worldwide and nearly 200,000 deaths in the United States alone. Hospitals and healthcare networks have been uniformly challenged to provide care and safety for patients and providers. In response to this initial wave, elective operations were canceled as a strategy to increase critical care resources, preserve personal protective equipment or PPE, and redeploy surgical team members to support care for COVID-19 patients. On a worldwide basis, this amounted to cancellation of a substantial number of operations, and a significant fraction of these backlogged operations were for cancer. Once hospitals recognized they could handle the size and peak of the initial wave, they resumed elective cancer operations. Some hospitals had the capacity to create COVID-19-free surgical units for these operations as a strategy to reduce risk of cross-infection of patients. Subsets of cancer patients are known to be at higher risk from COVID-19 morbidity and mortality, including those with lung cancer. However, creation of parallel pathways for COVID and non-COVID cancer patients diverts resources and is associated with significant costs. The relative value of this maneuver is not known, but is of critical importance, particularly in light of catastrophic hospital finances created by the pandemic. In the article that accompanies this podcast, the authors studied the impact of creation of COVID-19-free surgical facilities. Specifically, they gathered data from 445 hospitals in which patients underwent operation either in a COVID-19-free surgical pathway or alternatively underwent operation in a hospital that did not have separate COVID-free surgical units. The study included over 9,000 patients that underwent cancer operations during the pandemic. Hospitals in 54 countries are included, though the United Kingdom, Italy, Spain, and the United States accounted collectively for over 60% of the patients. A surgical facility was defined COVID-19 free if it had a policy of segregation of COVID-19 patients in 3 specific areas of the hospital: the operating rooms, the ICUs, and the inpatient units. Conversely, a surgical facility was not considered COVID-19 free if this segregation was absent in any of the 3 areas. There are several key findings. First and foremost, patients who underwent surgery within COVID-free units were younger and had fewer comorbidities compared to patients operated on in non-segregated surgical units. After adjustment for these differences, pulmonary complication rates were lower amongst patients operated on in COVID-free units compared to those operated on in non-segregated surgical units. The postoperative SARS-CoV-2 infection rate was lower in COVID-free surgical units, 2.1% compared to the 3.6% observed in non-segregated units. The preoperative COVID testing rate was higher in the COVID-19 free surgical units. Specifically, the testing rate was 39% in the COVID-19 free surgical units and only 23% in the non-segregated facilities. However, in a sensitivity analysis for patients with a negative preoperative swab test, the benefit of COVID-19 free pathways remained apparent. The authors conclude it is likely that differences in the SARS-CoV-2 transmission rates are responsible for the lower pulmonary complication rates in those operated on in COVID-19-free surgical units. The authors cite these observations as the basis for their recommendation for, quote, major international redesign of surgical services based on local available resources to provide elective cancer surgery in COVID-19-free surgical pathways, end quote. Of note, there are many hospitals and healthcare networks in the U.S., let alone worldwide, that don't have the resources required to create COVID-19-free operating rooms, ICUs, and inpatient wards amidst a devastating pandemic. And thus, it's imperative to understand if that is really the lesson learned here. It is relevant to point out that COVID-19-free surgical units, whether they cause a lower rate of postoperative complications or are merely associated with these outcomes, are sought out by patients. In my own surgical practice, once we resumed operations after the initial COVID-19 wave, some patients declined or further delayed vital cancer operations for fear of SARS-CoV-2 at the hospital, despite my assurances of the strict infection control policies in place. There are certainly limitations to this study. The first is that selection bias was present. Patients that underwent operation in COVID-19-free surgical facilities were significantly younger and healthier. Although statisticians have developed strategies to adjust risk in scenarios like this, these approaches do not always completely remove bias. The second limitation is that this study took place at a time during which relatively few patients were COVID-19 tested prior to operation. Some of the observed effect in this study may be related to unknown SARS-CoV-2 infection in asymptomatic patients. Only 27% of patients underwent preoperative SARS-CoV-2 testing in this study. Going forward, all patients are tested prior to surgical procedures. The current study suggests an effect even when the analysis is limited to patients that were tested preoperatively, but a more robust analysis of a postoperative transmission of infection in non-segregated facilities can be performed when all patients are tested preoperatively. Another important limitation of the study is that the definition of COVID-19-free surgical pathways was arbitrary in the degree of completeness. In the context of this retrospective multi-institutional international study, the definition was relatively broad for purposes of inclusion, but simultaneously lacks some common sense, relying only complete segregation of operating rooms, surgical ICUs, and inpatient wards to separate COVID-19 infected patients from those without infection. To be designated as a COVID-19 free facility for purposes of this study, it was not required to have segregated facilities for preoperative check-in, separate recovery rooms, separate emergency rooms for patients presenting with postoperative complications, or even separate equipment and staff. What is the impact of sharing with COVID-19 areas patient transporters, EKG and X-ray machines, food service racks, language translators, or use of common elevators and corridors, or even common pneumatic tube canisters in a pneumatic tube system that runs throughout the entire facility? If the best performing hospitals that don't have COVID-19 free pathways perform better than the worst performing hospitals that do have COVID-19 free pathways, what is it that these hospitals are doing that makes the difference? In short, it seems more than just plausible that establishing infection control standard operating procedures, or SOPs, staff training, and staff adherence to these SOPs are key to controlling spread of infection. These are likely as important as segregation of just 3 parts of perioperative care. In other words, this study demonstrates an association between having separate perioperative facilities and a reduction in pulmonary complications, but this type of study is unable to address whether a causal link exists. Perhaps hospitals with the capability of achieving this segregation through duplicate facilities simply have more resources. Perhaps they have more capable hospital administration and support that can more quickly implement the newest infection control policies. Perhaps they have more PPE for hospital staff. Given that many hospitals and healthcare networks do not have sufficient resources to create parallel, non-segregated COVID-19-free facilities for operations, drilling down on these important operational aspects for control of disease transmission is key. The time period involved in the current report was one during which hospitals were struggling to cope with several challenges. Of note, between May 14 and July 14, CDC data revealed that an average of 120 patients per day became infected with SARS-CoV-2 inside U.S. hospitals. During this time, hospitals were managing gaps in testing, as were evident in the current report, and shortages of PPE required to protect staff and patients. CDC data suggests hospitals have improved at controlling nosocomial SARS-CoV-2 infections since then, with the risk dropping from 2% in mid-May to 1.2% as of mid-July. These promising results are likely the result of better infection control methods employed over time. The impact of this downward trend was exemplified in a study from Brigham and Women's Hospital that demonstrated only one case of nosocomial SARS-CoV-2 transmission over 12 weeks of the pandemic, in which 9,149 patients were hospitalized and 8,656 days of COVID-19 related care were provided. The infection control strategies they implemented were thorough, improved over time, and did not involve a COVID-19-free surgical pathway. The most recent changes implemented in the Brigham and Women's study included enhanced eye protection for employees, universal testing on admission, daily nursing screening for COVID-19 symptoms, and a hospital-wide shift to N95 masks for routine COVID-19 care. The current study focused on cancer operations, but does control of SARS-CoV-2 transmission inside hospital surgical units have as much impact on other kinds of operations? Yes, the observations are relevant more broadly. Cancer patients are at greater risk for developing severe complications from COVID-19, but a large segment of the adult population has at least one underlying risk factor for increased susceptibility to infection, as well as increased likelihood of severe complications or mortality. Razagi et al. Have determined that the prevalence of any of 5 underlying non-cancer conditions associated with increased risk for severe COVID-19 associated illness amongst U.S. adults is 47.2%. Moreover, particular races have significantly higher risk of infection and higher risk of severe complications. Some healthcare systems have the resources to create separate surgical units to control nosocomial transmission. But going forward, it appears that reducing in-hospital transmission of SARS-CoV-2 to cancer surgery patients will rely primarily on rigorous implementation of aggressive and widely accepted infection control policies. This concludes this JCO podcast. Thank you for listening.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement. For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.